Hello, everyone, and welcome to today's webinar, A Patient-Centered Complex Care Research Agenda, Recommendations for Collective Action made possible by the Patient-Centered Outcomes Research Institute, also known as PCORI. We're delighted to have you here today for our presentation and panel discussion. Next slide, please. We really want to hear from you, so please submit your questions using the Q&A icon located at the bottom of your screen. We will be collecting questions throughout the webinar, and we will address them in the Q&A portion of the agenda. A brief online evaluation will pop up on your screen following today's event. Your feedback is really important to us, so we hope that you take a moment and complete this survey. Next slide, please. So let's go over today's agenda. The first portion of today's webinar will discuss the need for a patient-centered complex care research agenda, and will provide an overview of the recommendations. We will then move into a panel discussion where we will more deeply explore the recommendations and opportunities for implementation. Please submit your questions throughout the session, and as I said, we will get to those in the Q&A. Next slide, please. Here are goals for today's session. We want to ground our conversation today in understanding the need for a complex care research agenda that truly embraces patient-centeredness. We also want to describe the research agenda goals to better understand what we set out to accomplish. During the panel discussion, we'll dig into the opportunities to coordinate efforts and capture what matters most to patients. And finally, we hope today's session will provide you with ideas to explore incorporating the research agenda's recommendations into your own work. Next slide, please. As I said, welcome, and I'm Anna Benyo, Senior Program Officer at the Center for Healthcare Strategies. I'm joined by my colleague, Rachel Davis, former Director of Complex Populations at CHCS, and currently serving in a consulting capacity. Next slide, please. I'd like to take a moment just to say a few words about CHCS. We work with partners across Medicaid and related programs to ensure more effective, efficient, and equitable care that leads to better outcomes for more people. Next slide, please. We did this work with support from PCORI, as I mentioned, and our great partners from the Patient and Family Centered Care Partners, the National Center for Complex Health and Social Needs, and the Institute for Healthcare Improvement. Next slide, please. And I'll turn it over to Rachel Davis to review the research agenda recommendations. Thank you.
Great, thank you so much, Anna, and thank you to everyone who's on the line and to our panelists who you'll meet in just a second here. And I also just want to underscore thank you so much to PCORI, our funder. Obviously, without their support, we would not have been able to carry out this project, and we're so appreciative that we had the opportunity to undertake this work. So I'm going to do a little bit of level setting for today and provide a quick overview of some of the core concepts that we were talking about and building our assumptions on for this project, and then how this came together, and then really the nuts and bolts of what the research agenda itself says. So before we get into the recommendations of the research agenda, I just want to ground the conversation in a couple of terms that we use to frame our thinking around this project. They're up here, as you can see. The first is a definition of complex care, and this definition actually came from a messaging guide that the National Center for Complex Health and Social Needs and CHCS released at this point. It's probably been maybe 3 or 4 months ago. And the way that that messaging guide defines complex care is that it is a person-centered approach to care that brings together patients and their families, the community, and the healthcare system to improve health outcomes and well-being for people with complex health and social needs. The second definition up here is the working definition that we used of who people with complex needs are. And I just want to say, like, from the get-go out here, we fully recognize that this is not a comprehensive definition of who people with complex needs are. There's actually, no single agreed upon definition of this term right now. And so, for our purposes, we needed to put some parameters around who we were talking about in the complex care universe. And so we ended up focusing this research agenda on adults with complex health and social needs whose incomes do not always cover basic living needs, such as food, transportation, and housing. There are, of course, a lot of other definitions out there and a lot of other folks who absolutely meet this definition of having complex health and social needs, kids, for example, elderly adults. And, again, this is not to negate that those populations are out there. It's really just to say that for the purposes of this research agenda, the slice of folks that we were looking at were adults with these complex health and social needs. So those are just some framing parameters to help make sure we're all on the same page as this conversation goes forward. Travis, if you can go to the next slide. I'm going to speak briefly to why we thought that a patient-centered complex care research agenda would be useful in the first place. There are a couple different reasons for this. One of the first things that really came up for us as we were exploring this project was that, we just recognized that there was a lack of really strong evidence within the complex care field, and folks were kind of doing research in different ways and studying different things and measuring different things and asking different questions, and that made it really hard to generalize the results of all the different research efforts that were going on. And so ultimately, even though the field of complex care has now been around for over a decade, it has meant that we still don't really have a great, solid, robust evidence base to help us understand what aspects of complex care is really working for whom. So we just first and foremost really saw a need to coordinate the field to help build a stronger evidence base. Another reason why we felt like a research agenda might be useful is because to date, most of the research that has been done on complex care has mostly looked at essentially two measures, and they're related, but how do complex care efforts change healthcare utilization? And typically that means, do emergency department visits and inpatient admissions decrease or increase? And again, related to that, what is the impact of complex care programs on cost? Do complex care programs save money? Those are important measures, but it's a very limited way of looking at the impact of complex care efforts. And it doesn't really measure things that matter most to patients, and frankly, probably, the healthcare providers and the care team members doing the work. So we really felt like we were probably missing a lot of the other impacts that complex care is having just because we're not measuring them. Another reason why we thought a research agenda would be valuable to the field is because to date, there hasn't actually been very many examples of research efforts that really strongly demonstrate collaboration with patients and community members. And so that means that oftentimes research is being designed that probably reflects researchers' perspective of what needs to be studied, but not necessarily patients. And we know that those things can be very, very, very different. And so that lack of patient-centered input in the way that research is being designed or the types of things that are being measured really means that there's a disconnect between what we're studying and what matters most to patients. And then last but not least, and this is sort of connected to all the things that I just talked about, we recognize that we just needed a more nuanced evidence base. So, we sometimes talk about complex care as if it's like a one size fits all kind of thing, but we actually know it's not. There's lots of different kinds of folks within the population that I described on the slide before, there's lots of different kinds of needs, there's lots of different kinds of settings, and we haven't really done a great job of kind of parsing out that distinction, which means we really don't understand sort of how to tailor this work to different populations and settings and which interventions work best for which folks. So the sum total of all of that really led us to think that a patient-centered complex care research agenda could be a valuable tool for coordinating the field, building a stronger evidence base, and ultimately helping us create stronger, more effective complex care programs. Next slide, please, Travis. So I'm going to get into the nuts and bolts of the research agenda here, but wanted to read this quote from Suzette Shaw, who is one of our just wonderful patient and family advisory board members, and I think just really exemplifies everything that I just said much more succinctly. So Suzette said when we were having a conversation about why this kind of work is needed, we have not only lived a journey critical to complex care research, but our intersectionality of living in communities, as well as intergenerational family dynamics, enlighten our understanding of complex care issues. This depth of introspection may not always be gained from professional practitioners unless they have lived experience themselves. So I think that just really sums up beautifully the value that collaborating with patients brings to this work and what we're missing when we aren't making space and really making an effort to have patients as partners in this work. So Travis, can you go to the next slide here? So we pulled this research agenda together using a variety of different approaches. It was a many months long process. CHCS actually began the project by conducting an environmental scan, which really allowed us to kind of get a sense of the current state of the complex care research landscape. So we reviewed a lot of articles, we did interviews with over 25 people, many of whom are individuals with lived experience, and that really helped us get a sense of what seems to be working well in the current state of complex care research, where there's some challenges, where there's some opportunities to improve. And that gave us a platform to build the rest of the project and really direct the rest of the project activities. So following that environmental scan, one of the first things that we did was pull together a couple of different advisory groups that consisted of individuals with lived experience, patients. So we had two of those groups, actually. We had a patient and family advisory board, which consisted of 7 members, some of whom are gracing us with their presence today on the panel. And then we also had a research community. And so we used the Patient and Family Advisory Board, or the PFAB, to be a very, very involved advising board to us on this project. We met with them once a month. We reviewed all of the project materials with them. They saw probably more drafts of the research agenda and the environmental scan than they cared to see, and helped us massage and make sure it was on target and really speaking to the patient-centered nature of this work. I really can't understate how critical they were to making sure that we were really living up to the patient-centered ideals of this project. The research community was also really essential. They were a sounding board for us, and we would send them materials to react to and also really help shape the research agenda itself. And both of these groups, members of these groups, participated in the work group sessions that we held. So we held 5 work group sessions over the course of this project, which, as I just said, involved PFAB members, research community members, as well as 10 organizations from all over the country who are immersed and active in providing complex care. And in those sessions, we really rolled up our sleeves and workshopped what this research agenda should consist of. We had 90-minute, very focused sessions, really walking through what research questions should we be asking, what measures should we be looking to. how should we be ensuring that this work is patient-centered? So again, these were really roll up your sleeve sessions that ultimately contributed to what you see in the research agenda. And then lastly, we sent out a survey to complex care stakeholders, several hundred of them, got some great responses from that. And so ultimately, the recommendations in this research agenda are a reflection of the collective input of all of these stakeholders. And we're very, very appreciative for all of the work and contributions that these folks provided here. So let me spend the rest of my time here walking us through actually what the research agenda says. So Travis, can you go to the next slide, please? So in the research agenda, we put out 3 key recommendations for the field. You can see them up here. The first recommendation is that the field should and can more meaningfully partner with patients and communities in research. The second recommendation is that the field focus on a prioritized set of research questions. And the third recommendation is that the field measure outcomes in a more consistent and patient-centered way. So let me unpack that a little bit. Travis, if you can go to the next slide, I'll start speaking to this first recommendation here. So this first recommendation is really speaking to this idea that patients and communities should be partners in all stages of the research, and that participating should be as easy as possible. So in order to do this, there's a couple of different levels of work that research teams need to undertake. So the first thing is that a whole sort of package of patient and community engagement skills that need to be grown and expanded. So this includes things like making sure that anytime that research is being conducted and patients are pulled in as collaborators, which again, ideally is all the time, all the research projects, research teams, all the members on research teams are familiar and comfortable with cultural competency, some of the tenets of cultural competency. Project materials and timelines are developed in a way that accommodate patient needs. Trusted messengers like community health workers or peers are being used to help create a safe and trusting space. Principles like trauma-informed care are being implemented to make sure that, as patients and community members are pulled in, we're not traumatizing them or re-traumatizing them in the process of collaboration, et cetera. So there's a lot that we put in the research agenda that sort of falls into this patient and community engagement skills bucket. I'm not going to go through all of them, but hopefully that gives a sense of sort of what we mean on that side of things. And then there's also a aspect of this that's related to using different and new research skills or practices or designs. So one of the first things that we talk about in the research agenda under this bucket is that research teams and healthcare systems really need to invest in building their trustworthiness. So I'm guessing many of you on the line have a sense of this, but I would say healthcare doesn't have necessarily a super great track record of being a trustworthy research project. It hasn't been unusual in the history of healthcare for, research efforts to sort of parachute into a community, conduct an evaluation or a research study, and then just leave and sort of leave the community feeling like information was extracted and there was a lot of transparency, and in some cases the results being abused and misused. So I think that one of the first things that the field needs to acknowledge is like there's an investment that needs to be made in proving themselves as a trustworthy partner. And one of the big things that I would say falls into this bucket is, investing in transparency, being very clear up front about, what the goals of the research are, who's involved, sharing the data, seeing data as a shared resource that is, just as valuable to communities as it is to researchers. So there's a whole sort of a bucket of activities under that, bucket, I would say. There's other, in terms of research design, there's certainly other types of, there's research designs that lend themselves to being more patient-centered. So some of the ones that we lift up in the research agenda include things like community-based participatory research, thinking about qualitative research as opposed to quantitative research, or even more longitudinal research, are all research methodologies that create a little bit more space for understanding what matters more to patients. And yeah, again, there's a lot in the research agenda here, so I won't go into everything, but hopefully that gives everyone in the audience here a flavor of what we were getting at when we put forward this first recommendation. So Travis, if you want to go to the second recommendation here. So second recommendation, again, is to focus on a prioritized set of research questions. And again, a lot of the impetus here was recognizing that a lot of the research that has been done to date is sort of, there isn't necessarily a lot of uniformity to it. And so it makes it very hard to take the results of one research study and know if we can generalize it or apply it to all complex care programs. And so the more that we can hone in on sort of a core set of research questions and consistently be asking these questions, the more easily we'll be able to compare results, which will allow us to, build the evidence base in a faster way. That was one reason why we felt like there was an opportunity to, to lift up a recommendation around focusing on a prioritized set of research questions. Another aspect of that is that, as we were doing these workshops and connecting with our patient advisors on the PFAB and the research community and doing the environmental scan, these were the questions that really rose to the top as just being kind of like the gaps in our understanding that we really need to fill in order to make sure that complex care is as effective as possible. I'll just read through the questions here. The first one is asking, what services and approaches are most effective for which patients and why? Again, getting at this idea of like, we just don't really have this fine-grained, nuanced understanding of how to tailor different approaches to different people at different times and different settings. Right now we're sort of in some ways taking a little bit of a one-size-fits-all approach, and we know we need to get more nuance there. So really digging into that nuance is what that first question is getting at. The second question is asking, how can the different people and organizations who provide complex care services effectively coordinate with each other? And how does this affect care? So we know that there's tons of players in the complex care space. And one of the challenging things, I think there's sort of an inside joke in complex care, like sometimes you need somebody to coordinate the coordinators. So it's great that there's so many players, but we really don't actually have as much of a sense as we probably need about what it takes to have all of those players working effectively with each other and what that does when that is sort of optimally coordinated. The third question is around the role of trauma-informed care and using a trauma-informed approach in complex care programs. I think at this point it's fairly conventional wisdom that trauma-informed care and using a trauma-informed approach is a sort of prerequisite for any complex care program. But again, we actually haven't really studied this one very much. And so really digging in, getting more evidence, more concrete, solid evidence to help us understand what is the impact, what does it look like when you do this well, what is needed to do this well would be really valuable. Fourth question here is around what gaps in services and resources need to be addressed in order to fully meet the needs of individuals with complex health and social needs. And this is really speaking to the fact that, complex care at its root is really trying to address really, really, really challenging issues. And sometimes issues that are reflective of broader gaps in the system, things like systemic racism or, for example, redlining or, disinvestment in communities, like these big sort of systemic forces that really mean that when complex care programs are working in particular environments, there might only be so much that they can do without some additional gaps being addressed. And so this question is really trying to get at, like, what are those gaps? How can we best address them? What are the additional services that we need to make sure are there in the environment in order for complex care to be as effective as possible? And this last question is around what impact setting has on complex care efforts. And the term setting, we mean a bunch of different things here. I'm sure a lot of you have been involved in conversations around, complex care programs that take place in urban settings. It can be really different than complex care programs that take place in rural settings. So that's one of the ways that we mean setting. But we also mean, where is the complex care program or the complex care efforts based? There's a difference between complex care efforts that are based in hospitals versus ones that are led by payers versus ones that take place in the community. And we also actually in this sort of also are referring to, like, who's paying for this work? Again, the sort of like the locus of that can also really influence complex care outcomes. We think we haven't really studied that very much. So that's what we meant by that last question there. So again, these were sort of the key questions that came up over the course of the workshop and all of our conversations, and we're recommending that the field focus on moving forward. So Travis, if you can go to the next slide. The third recommendation that we had was to measure complex care outcomes in more consistent and patient-centered ways. So I already spoke to the fact that, for the most part, we typically measure complex care right now on cost and utilization measures. And you'll see cost and utilization on here. Again, that is an important measure. Those are important measures. We're not saying that, people shouldn't pay attention to that, but there's probably a lot more that we can measure to help give us a fuller understanding of complex care outcomes. So there were 5 categories of measurement that came through during our process of collaborating with stakeholders around this recommendation. This first one is patient-centeredness. And so what we mean by that is measuring things like to what degree patients are included in the design and decisions associated with their care, using patient-reported outcome measures to get the patient's perspective on how well they're doing and the impact of the program, assessing how much patients feel empowered, whether they feel like they're being treated with dignity, if they feel like they're being listened to, things like trust in providers. What's the degree of trust that patients have in their providers? So that's one of the, those are some of the things that we meant by patient-centeredness. The next bucket that you see here, or category that you see here, is racial and health equity. So by that, we're talking about really just making sure that we're being sensitive to these forces when we're evaluating complex care efforts. And there's ways to accomplish this, for example, by making sure that we are collecting data and stratifying and analyzing data through demographic factors. There might be interesting ways of including geographic or community level data that might provide some additional insights into, again, some of the historical and social forces of racism and inequity and how those might be affecting outcomes. Probing with patients, understanding, measuring with patients their sense of whether they're experiencing bias or discrimination in their care. So that's those are some of the pieces that we meant there. Okay, for quality of life, this third bucket, I think this is one that we hear about a lot when we talk about what's missing in the current state. And so With quality of life, we're talking about things like measuring well-being, looking at how complex care efforts impact caregivers and families and the kids of individuals receiving complex care services. Things like how does complex care impact social connections and relationships. So really moving away from, sort of these cost and utilization metrics and really trying to get a better understanding of what are patients' experiences of care. The fourth bucket here is coordination of care and systems. And so, as I spoke to, there's a lot of different players in this space, and patients' experiences of care can feel oftentimes very fragmented and very uncoordinated. And so one of the ways that we might want to assess how well complex care programs are doing is by looking at how well complex care systems and how well care is being coordinated. So that's one of the so that's one of the measure categories that we were thinking of. So, this could look at things like patients' experience of navigating care systems. How long does it take providers and systems to respond to patient needs or to schedule follow-up appointments? To what degree are all of the different care team members collaborating with each other, all the different players that are touching this patient meeting with each other. I'm not going to go into cost and utilization because I've sort of spoken about that ad nauseum, but again, hopefully that gives you all a sense of what we were thinking of with those measures. And I do want to acknowledge upfront here that, one of the challenges to doing patient-centered research is that there hasn't been a lot of validated measures developed in these categories. And so that actually is probably a good segue into my last slide here, which is some of the recommendations for next steps. Now that we've put out these areas of focus that we think complex care should turn its attention to in research efforts, like what are opportunities to, to really bring some of this to life. So I won't go through all of these. They're in the research agenda. You can read them here. But one of the things that we do say, that, this fourth bullet is, maybe there's a really important opportunity here for complex care to develop some core measures, patient-centered measures, validated patient-centered measures, and make sure that research efforts are, using at least some consistent core set of these measures and all of the evaluation efforts that it carries out moving forward. So I'll just hone in on maybe one or two of these other opportunities that we pulled out here. But one of the things that we really heard from the folks that we talked to is it can sometimes seem like complex care feels like it needs to reinvent the wheel, when in fact there's probably a lot of existing evidence that's already out there from other fields. For example, the field of HIV has done a lot of work figuring out how to tailor models and tailor outreach and figure out who the subpopulations are. The field of behavioral health has done a lot of research. Like there's probably a lot of research that's already out there that we can borrow from and just be savvier about applying. So there's probably a lot of opportunities to dig into that existing evidence base. One of the other ideas that came out was this idea of building a complex care practice-based research network, which would sort of offer an opportunity for a centralized way for sites across the country to be researching the same thing in different settings, sort of having a centralized place where the data could be analyzed, and really just trying to get at this idea of making it easier to generalize research findings, conduct research in more consistent ways so that we can more quickly build the evidence base. So just for the sake of time, again, I won't go through all of these. I will wrap this piece up here. And Travis, if you could go to the last slide, I think we have one more quote from one of our PFAB members, Lakeisha Dumas, who said, sometimes numbers don't go down medically, but that doesn't mean that people aren't happy or joyous because they're getting needs met. And I think that really sums up, why we need to be thinking about the value of complex care and what we're measuring in different ways, and the value that a patient-centered lens can bring to this work. So I'm a few minutes over. I'll pause there and turn it back to you, Anna. Thank you.
Thanks so much, Rachel. We're now going to go into a deeper conversation on a lot of what what Rachel just covered and talked about in terms of the recommendations and some opportunities to bring that forward. I'm thrilled to introduce our panel today. We have Alan Coker, Melissa Goppel, and Doris Maldonado, all of whom have partnered with us as members of our Patient and Family Advisory Board. They're going to bring a lot to this conversation, and I just can't wait for to hear their thoughts. We are also joined by Amanda Johnson, Assistant Vice President of Care Models at New York City Health and Hospitals, and Kara Nikolajinsky, Director of Research Design and Implementation at the University of Pittsburgh Medical Center at the Center for High Value Healthcare. Welcome all of you, and thank you so much for being here. You can all come on camera now, and we can get started. Great. It's lovely to see your faces. So we just heard a lot about the themes in terms of what we're going to talk about in today's panel discussion. So our goals for this conversation are really to explore the need for taking a patient-centered approach to research, how this will benefit the field of complex care, and opportunities to put the recommendations and implementation opportunities in the research agenda into some tangible next steps that you can carry out in your work. We are going to kind of have this conversation, and you'll hear some reoccurring themes about centering patients in all areas of complex care research, engaging stakeholders, implementation opportunities, and ultimately translating all of these learnings into better care for people, which is ultimately the goal here. Alan, I'm going to turn to you first. We heard a lot about engaging patients in all areas of research. From your perspective, what does meaningful patient engagement in complex care research look like?
Well, I know Rachel covered a lot, so I'm just going to try to get like a little bit more detailed and specific. It means having a mix of people involved from day one, hospital level, community level, whether you're going to a healthcare clinic. You need advisories of individuals that get services that represent the community. That's ideal. I mean, if it's, the mixture of the community, the language, hearing impaired, elderly, youth, you need everybody involved, not just handpick people by the hospital or you don't need them to handpick it. You need grassroots people. You need us, people that have been through it, to speak what we need for healthcare. You need people that are on Medicaid, Medicare. You need their input. You need. I'm not too far outside Harvard. You need bilingual. You need the communities that are all served. You need it to represent the people that they serve. We sat on some work groups. And I was amazed because I was able to deal with a doctor from New York who talked to me as a peer, as an equal, and I'm just a consumer. We need that type of healthcare, and we need to talk in plain language. Simple, not over our head. We just need someone just to sit there and explain. It's not that complicated. Most times, whether we got Medicaid, Medicare, they're billing the insurance company for 30 minutes. Utilize that 30 minutes and they can talk to us as an equal. Talk to us, explain. And then if we have a question, don't be offended. We're the consumer. There's an expression that was going around, I hear it a lot lately, nothing about us without us. We're included in the conversation, so whether we're working with doctors or what, we're getting services. We have a right to ask for doctors. We have a right to ask questions. I don't hear too much anymore of getting a second opinion. Some doctors several years ago would say, well, you want a second opinion, check with so-and-so. They don't do that no more. That conversation, has to take place because we are the consumer. We have a right to say, well, I don't understand this treatment, or I want another treatment. We have a right to disagree sometimes, or not accept, or get asked, other options. So that's what, I think it just needs to be a lot simplified. All city level, state level, national level. If I go from where I'm living in my town to another town in my state, it shouldn't be complicated. If I go out of state to get health care, it shouldn't be complicated. It shouldn't be that detailed. It shouldn't be that complex. It should be across the board. But that's just in my dream world. I don't know if I'm going to see it, but I would like to see it that way.
Thanks so much, Alan. I really appreciated what you said about this coming from grassroots efforts and communities, and that you can't just sort of handpick a couple of people. That really, if you're looking for like meaningful patient engagement, you're going to have to look to communities and grassroots efforts to engage. So I really appreciated that. I'm going to just pivot the conversation a little bit and just wonder if Kara, if you can share your thoughts on research methodologies that incorporate patient-centeredness in complex care efforts, because that's really, we take the need for engagement and then move it into sort of, how do we do that, some of that?
Yeah, I think with everything Alan just mentioned, community-based participatory research would really get at a lot of what you were talking about, finding those people local in the community that are experiencing whatever you want to study every day or have those connections. I think that's critically important. It takes a lot of time to build that trust, but then you find yourself engaging from the start in, even developing the research questions, coming up with the interventions. So it's really valuable. Something we do from a study perspective is we make sure that we take a mixed methods approach to all of our studies. So really incorporating not only the quantitative measures, but also doing qualitative interviews or focus groups to really get at sort of the nuanced information to help paint the larger picture of what's happening. And in doing so, we take many steps to incorporate patients into that process. So not only interviewing them or doing focus groups with them, but also having patients or other stakeholders help inform the interview guide to make sure that we're asking the questions that are relevant and meaningful. And then also, sometimes we even work with patients and stakeholders to conduct some of the interviews when it's appropriate. And then finally, with the interpretation of the findings, sort of having other stakeholders, patients, caregivers look at the findings from the quantitative perspective, from the qualitative perspective, and help the research team really piece that data and that information together to paint, I think, a more robust picture of what's happening. And then last, I'll just mention, we do a lot of sort of less formal, non-researchy type methods to engage stakeholders throughout our processes. Some of the things we always incorporate into our research studies is a stakeholder advisory board, which meets periodically to inform all elements of the research from implementation to dissemination and beyond. We have done community engagement studios, which allows patients and other stakeholder groups to give feedback on certain elements of a research project. So things like that, I think, are also critically important, not just focusing on the more traditional research methods, but also other ways that you can engage people throughout the research life cycle.
Thanks, Kara. Does anyone want to just mention anything else before we move on to the next question? Any initial thoughts? No? Okay. So that's really helpful. And, I think, Alan and Kara, you've kind of laid out, different pathways of engagement and how to ensure that there is a patient-centeredness in all areas of research moving forward. What are some of the obstacles, Kara, that you see in terms of carrying out patient-centered research, and what would be some ways to address this, if any?
Yeah, sure. I think one of the obstacles that we have faced is how to sort of identify and interconnect the data sources that will help you measure your outcomes most effectively. So what I mean by that is, complex care is not just something that occurs within a healthcare system or a doctor's office or a hospital. It occurs in communities, it occurs within families. So how do you sort of set up from the outset your capacity to collect data from all of these resources? So how do you work with a community organization to get them integrated into the research process, to know that you hope to collect information from them, for example, about an individual's use of their services and how that's affected their care and outcomes. There are, fortunately or unfortunately, data agreements and processes that all have to be put in place that can take time. So knowing that up front, I think is critically important. So planning ahead. I think making sure that you're working with stakeholders early on to identify some self-reports outcomes that are of critical importance. So working with patients to understand what outcomes are most relevant to them and make sure you are collecting data directly from them, whether it be qualitatively or quantitatively, to make sure that their voices are heard and integrated. Trying to think of what other nuggets of information I could give you. I think those are the main ones. Another challenge, but something that's critically important, is finding a way to, when appropriate, collect information from folks like caregivers and family members. That can be a little bit challenging, and it does require some additional, on the back end, what are your consent procedures going to be like? How are you going to get that data from them? What outcomes are important to them, because we know that there's caregiver burden and other things that should definitely be assessed to benefit caregivers and not just the patients. So I think those are probably my two main points.
Melissa, I see your head nodding a lot. Did you want to jump in here?
I agree with a lot of the stuff that she says. What comes to my mind is, in talking about collecting that data and what is qualitative and what is quantitative. I know personally, as an advocate, advocate has developed like a negative connotation, because they always assume that when you're advocating, you're going to be adversarial with them, but that's because you're challenging the status quo. And I'm always the one pointing out, how are we accommodating people? How are we providing accessibility? And then, in the medical realm, like, we report stuff to our providers. And a lot of times, when I compare that and then compare stuff to research and peer-reviewed published studies and what have you, there's this other word that comes up, anecdotal. And like, it devalues our experience or reporting of our symptoms, especially when it comes to things that you do that may be alternative, or even when it comes to just straight up basic nutrition. How do we participate with research when we are discounted and devalued or excluded in so many ways? This research agenda can move that thought, that whole just, theme of how are we making things accessible? How are we assisting people to participate and be a part of something that may or may not directly impact them, but may contribute to, what others are able to experience or access. The other thing about, I'm always the one that brings up the disability issues, but many of us have hidden disabilities, and the accommodations we need don't always require financial resources, but like Alan was saying, they do require some additional time often. Or maybe if the doctor doesn't have the time to explain something that we're questioning, that's why they have support staff. Can they, have their PA or a nurse, or if they have an in-house social worker that can provide that additional explanation? Or some of us, when you're on Medicaid managed care, if you check certain boxes and you get certain services through your healthcare, you're eligible for case management. Those people can also help you understand, because often they're RNs. So by their credentialing, they can provide that additional explanation and include you in your healthcare, include you in those decisions, include you in understanding. And they don't treat us like, oh, you're just being resistant to the treatment that's been, recommended. No, we have concerns. And yes, what we've done may be anecdotal, but it may have value in certain aspects. And I know, like, look at herbs. They've done tons of research on specific herbs. And prior to that, it was anecdotal. but now we actually have evidence as a base to show, what those mechanisms are, how those things work in our body. So it just, I'm so excited about this because the research, we can go in so many different directions, but including us from the ground level. And I see somebody had in the Q&A about community trust and like, how do you foster community trust? Providing baseline accessibility and clear, effective communication and meeting people where they're at is huge in garnering trust.
Yeah.
From both sides.
Right. Thanks, Melissa. There's so much there you said that I want to follow up on. But one thing that I think, what I heard was about, this and something that we talk about in the research agenda about the need to develop new skills. Like there will be a need for researchers, other stakeholders to develop new skills to do patient engagement in a way that has establishing trust, to have the kind of engagement that you talked about, Alan, having things accessible and have plain language. So there will be some opportunities to grow in those ways, and so I just wanted to highlight that in terms of something that you said. So that's really helpful, really interesting. I'm going to move us along a little bit and just pivot to Doris. How do you see a patient-centered approach to research playing out a role in addressing racial and health equity, which is something that we talk about in the research agenda as one of the domains to have further validated outcome measures for, and it's an area that's there are growing efforts to have those measures develop. And how do you see the patient-centered approach playing a role here?
Gracias for that, and happy Hispanic and Latina Heritage Month. I think this is very fitting to be on here. I have to take my camera off because I'm having connectivity issues, so please bear with me. It's how does anyone not see it? Patient-centered care and approach. I am not my disability, and I am a Latina born with differing abilities. Patients should fully participate in every stage of our life course. And statistically, according to the 2020 census, they've undercounted BIPOC communities. You add the languages other than English. The census also discloses communities with disabilities with linguistic differences, which adds an additional layer and barrier to marginalized with disabilities. So diversity, equity, inclusion has been mainstream nowadays, and yet access within diversity, equity, and inclusion and disability remain closeted. Racial and health disparities can only be successful with a patient-centered approach to complex care, intentionally inclusive of intellectual and developmental disabilities. We're a whole person. While care may be accessible, it may not be acceptable for my individual circumstances. So patient-centered care is not just an optional role. This must be at the epicenter when addressing racial and health inequities because of the disparities and implications for person-focused health and well-being. The misconception is that the Patient's Bill of Rights, some may see at providers' facilities, is a legally binding document, and that's not the case. It's not a standard of practice, especially not in marginalized communities who are taught not to question providers and authority. I was taught, do as I say, not as I do. The stigma and the shame are culturally paralyzing, especially when we are not empowered or engaged by providers, leaving the marginalized with disabilities further ousted and silenced. We trust because many of us have not been afforded an option. Crisis standards of care, as with the pandemic, survivability is the code red. Many of us don't fall into that. Those who are predicted to live beyond 5 years are prioritized. In my state, those with disabilities were next in line to access the COVID vaccine, and until our state administration switched it against CDC and national guidelines, The Friday before our Monday was to wait in line, we were remanded again to the end of the line, hoping to have access. I would have been buried decades ago, especially since the Latina and Black African Americans suffer from high morbidity rates from the moment that we are born. My parents were informed 2 days after I was born that I had congenital heart disease, and that would impact me developmentally, and that they should consider my viability. I lost my mother and 3 other matriarchs in my family every other month, as well as my son contracting COVID in 2020. My mother died with the guilt of giving birth to me with disabilities and blamed herself for my challenges. My parents were born in Puerto Rico. We're a Commonwealth, for crying out loud. And healthcare, even today, is in some parts of the island, is comparable to third world countries. We're not automatically invited to steer our own ship while being spoken for and to, rather than with and in support of. So we're the experts of our existence, but we're categorized according to our last names, demographics, and especially complexities. I've been greeted by providers who more often than not, just yesterday, greet me with a, "Wow, seeing your patient record, I thought you were older, but you started at such a young age." Then followed by, "Well, you have a complicated history," or, "You're complex and we just have to wait and hope for the best because yours is a unique case and medications and surgery are not an option unless it's absolute emergency." You need to make the best of what life gives you, I'm told. Oftentimes it feels like a disclosure allowing an out for the providers. After having a major stroke because of medical neglect, the doctor apologized to me saying, "I'm sorry, I'm human and you're complicated." He was virtually slapped on the wrist for not following protocol, and my life has never been the same, and I almost lost my sons. Many of us decades ago were either euthanized in infancy or prior to birth, if not sent off to camps away from visible mainstream communications like pariahs. Today, thanks to your research and other research, we are living longer, but BIPOC communities aren't yet keeping up equitably with that trend. But the world now experiences a pandemic and have taken pause because it's more personal than 1 in 4 of us impacted. It's all of us. Thank you.
Doris, just thank you so much for sharing your experience and your story with us and with everyone who's on the line here. You've taken something like so broad and jargony like racial and health inequity and brought it home and allowed us to understand a little bit about your experience and how that actually translates for you. So thank you for sharing that. Appreciate it. So one of the things that you brought up kind of earlier on was data, this idea of, you talked about the census and having, correct numbers and things like that. And so, that's one of the areas, that we talk about in the research agenda is just the extent to which we don't have good outcome measures on this yet, or tremendously reliable ones, and that this is a growing area for the field. And so, having reliable data and building that evidence base will go a long way in complex care to tackle some of these larger issues. And again, thank you for sharing your story about how it's affected you personally. So I was going to run, Melissa, you had me thinking about, when this comes time to grow the patient-centeredness in complex care research, like what sort of skills or resources do healthcare system researchers and patients need? This idea of what kind of skills would we be looking for, and what kind of resources are needed to move in that direction?
So first and foremost, I think coming from a background in the mental health realm, one of the trainings that I went through as a family advocate or parent advocate, helping families that had youth with mental health challenges, was learning how to do motivational interviewing. It's a way to elicit some of that qualitative information about how somebody that needs help can be also involved in their own solutions. And I think getting a perspective on not answering just straight yes or no questions, but those open-ended questions, thinking about it in a way that, if your research is designed to get X, Y, or Z as answers, what happens if, P or Q or S result? What do you do with that, right? Like, how do you incorporate that? Thinking about people in that same way, not so clinical and analytical, but just having those conversations, excuse me, having those conversations where you're getting open-ended information and, excuse me, allowing people to provide their own input and perspective. The other thing was, I'm always the pain in the rear end person that's pointing out the disability issues. I'm very outspoken about that. Not only the physical accessibility, but the what are the attitudinal barriers, and that directly relates to, the equity and inclusion. Diversity, equity, and inclusion is on everybody's mind right now because, they're putting forth these initiatives. It's taking these initiatives moving forward to like get it in everybody's consciousness. But, people with disabilities, the ADA was passed in 1990. It was amended in 2008. And here we are 32 years later, and people are still unfamiliar with what they need to and what they can do to make things accessible for people. That does not include, physical barrier alteration. It's how do we change people's perceptions? How do we open their minds to expand the solutions and options that are available? We have wonderful technical assistance resources, in the eastern states, the ADA, the Northeast ADA Center. They're based out of Cornell at the ILRU. There are technical assistance centers across the United States. It doesn't cost you anything. You can phone them. Most of them have an 800 number. They're on the World Wide Web. You can also go to, the ADA website. Is it ada.org? The National Technical Assistance that's if you need to look at like site plans and stuff. But that was how I found out that my son's daycare discriminated against my son because he wasn't effectively potty trained, but it was directly related to a medical issue. There was a whole like 14-page document that was the ADA applied to childcare centers. And it just opened up a whole world for me going, he has rights that I, as a parent, wasn't even familiar with. And then that linked me onto, all these different organizations. I think one of the skills as researchers, if you can start doing research on some of these topics of this publicly available information, and how do you incorporate that into your everyday life, especially when it comes to your work. We don't want to have to be punitive when we're asking for things, just like you don't want to have to be punitive. And somebody asked in the Q&A, what are some of the strategies to include us? Speaking with us like we're people, because we're all people. We're people too. But also helping us overcome some of those barriers to participation. So if there's a token compensation that, is not going to jeopardize our benefits, like, we have to have those tough conversations. If you give us compensation that cuts off our public assistance or impacts the amount of aid that we get that we vitally depend on, that's going to be a barrier to us participating. If we can't afford to get there, if we can't afford the gas for our car, or if we don't have a vehicle and we use public transportation, or if we're in an area where there isn't public transportation, and then how do we get there? And is there an alternate way for us to participate? Do you physically need us to be there? Like, we have to have those conversations. We're having them all the time ourselves, right? So we just want you to be cognizant and aware of that. And, we can help you come up with a solution, because most often we do. There's this culture of survivalism, especially for those of us that have, trauma past. And we also, don't acknowledge the medical trauma that happens, the gaslighting by the medical industry for those of us that have rare, unusual conditions, which is further traumatizing
Right.
and directly impacts our healthcare, our medical status, and our quality of life, and our willingness and ability to participate in all aspects of life, including trying to further research that may
Right.
eventually help us.
I think it's really important to change the tone of the research that's taking place. And I think a lot of what you're mentioning, Melissa, both very detailed specific examples, as well as this overall kind of resistance to change, the idea that you need to be an advocate versus it being this dialogue, is really inherited from a lot of the traditional research paradigms that we use when we're investigating new pharmaceuticals or new devices. And so I think part of that skill set that needs to be developed in our next generation of researchers writ large as a community of researchers, both from medical professionals to our community members, to our patients and our families, is being able to respond to change because it is inevitable. And I think that's going a little bit to just practical things we can do, and we're thinking about how to design a study or launch a study, is recognize that there are going to be different reasons for change. I think if we want to generate research that can inform system redesign or new policy, you can't just arbitrarily take a protocol and say, well, it's Saturday and we're going to change A to B. But there are going to be various reasons for changing, and you can account for that when you write up your discussion, when you address the limitations of a study, for those of you who will disseminate through manuscripts. A lot of our tools in the realm of implementation science and health services research help you try to address the facilitators and barriers of your intervention before you even launch it, before you actually put resources in the field, put new protocols in the field, so that you can have some sense of what you might learn before you actually go and say, okay, I'm pressing the start clock on my intervention. And then some studies even actually have a formal run-in period because you acknowledge that there is going to be a learning curve for everybody involved. And so it's important to acknowledge that there's a startup period, but you don't want to unfairly penalize an institution, a system, a group that's trying to test an intervention because they are learning and rolling out this new process, for example, or a new tool for the first time. And I think a lot of this also just comes from trying to bring more of a quality improvement lens to the work that we're doing, because we don't even say what is the reason for the change. It's like there should be change. We're designing this in terms of short interval sprints because we know we're going to learn, and the faster we learn, the better care we can deliver to our patients and our partners. And that is the reason we're doing all of this at the end of the day. I think the last thing that I just want to acknowledge here, in case it was unclear that I felt like this idea of control and this rigidity was a bad thing, it's something that is definitely limiting us. There are going to be things that happen beyond our control, and we need to have approaches to research that allow us to address those changes. For example, when I am thinking about evaluations we want to do from the last 2 years, in the last 2 to 3 years, we had a really big event that was outside of the control of, I would say, everybody on this call. And when we think about what we've learned in the past couple of years, these learnings, these insights are transformational. We should not throw them away. But I hear people, and myself have been in discussions where we're like, well, can we use the last 2 years as a representative baseline because we had COVID and therefore nothing is comparable. But I think we also have to realize that nothing's going to be the same. And that is just part of doing this work, is realizing that the goal line is always changing. Like what we're trying to achieve is always going to be moving. We have to respond to the context that we're living in, as opposed to this really pristine research standard that we've just inherited from other fields of inquiry.
Thanks, Amanda and Melissa. I'm really hearing a lot of, the ways in which complex care research can move in a direction that has that patient-centeredness. And you've given some really good examples, Amanda, about things that can be done, because what Melissa, you're describing is like the real life implications of these things and how it affects people on the ground. And Amanda, you're kind of speaking to like the ways in which research can address that, right? Can like actually respond to people's real lived experience. And so I appreciate that. I'm going to kind of move us into thinking about what we do with all this research and all these learnings. So we go through the process of researching the new things, but that's not really the end. That's, you know, we take that information and want to translate it, those findings, into policy and practices that help people and provide better care, which is ultimately the goal. So Amanda, I wanted to turn to you and just, get your sense about bridging that divide between research and practice.
Absolutely. So I think when I'm going to make a distinction between practice and policy. I'm going to think about practice as the kind of change that a group of committed individuals can institute in their local delivery setting, be it in a formal healthcare institution or in the community or whatever setting. And that's why we said it's important to find the setting that you're thinking of. And I think that part of it goes into making sure that we are studying things that matter in the first place, and all the comments that people have made before and the content of the toolkit that's been put together really compel us to think about not only studying the things that matter, but also setting us up to understand whether the results of these studies are going to be generalizable. So putting my primary care hat on, if I'm reading a paper, I want to understand, is the outcome of this paper, is what I'm learning from this research article, something that I can apply to the patient in front of me? How comparable are them? What ways are their experiences similar or different? And how might that impact the plan that we co-create? And the same thing is something I have to keep in mind when I'm thinking about how to translate what was learned from a piece of health services research to the setting in which I work. Thinking about it the other way, whenever I'm talking to a partner outside of my institution and I want to talk about what we've learned here at Health in Hospitals, I realize I have to start by talking about how Health in Hospitals is structured and who are our patients and who are our payers and what staff do we have on in our facilities, what staff do we have in the community, what is just a larger New York City context to help us have a conversation about whether my experience is going to relate to your experience, and if so, in what way. So I think really doing qualitative research and acknowledging setting is very important for allowing new practices, new settings of care to think about our evolving evidence base and understand what is applicable to them and how do I translate it to that setting. I think another, we'll get to prompts in a moment, I'm sure, but I'm so glad that that has been mentioned over and over again, because if we want to implement things, I'm also looking at, is this going to matter? Is this going to change the experience that my patients, my clients are having with the organization that I'm responsible for? I think one thing that was also mentioned before have been patient family advisory councils or patient family advisory boards or stakeholder boards. And they're important not just in determining your research questions and implementing your research and synthesizing the data, but when you have a new idea, your patient family advisory council is also an engine for thinking about, does this matter to the patients we're serving in this practice, for example? And if so, what are the ways in which we should be disseminating this knowledge to them and implementing it into the work that we do every day? So don't forget that kind of patient-centeredness goes all the way through. And also don't forget that the research cycle goes all the way through dissemination and implementation and sustainability. And so I also just want to give a shout out to PCORI and all the other organizations that really do think about dissemination of knowledge as part of the research cycle. And while it might seem, and I am talking a lot about, changes in organizational structure, I think about changes in process and workflow, I think about changes in the medical record. So these are all kind of those tiny pieces that, taken together and deployed with the right leadership and the right voices at the top, really equate to something that's even larger than just kind of the checking the box on process or checking the box on audit, but it is culture change. And I think once we have kind of 360 culture change about what matters in practice and what research we're looking to guide the changes that we're going to make, then I think we've really delivered on what this group has set out to achieve.
Yeah, I completely agree with everything Amanda said so beautifully. I think from the start, and you mentioned a lot of this, but from the start, really having an implementation science frame in mind and looking at all of those various factors that can impact implementation, whether it be sort of the inner setting, the outer setting, the individual, the provider, the community, really assessing all of this, having it in mind, keeping track of your findings. So when you do go to hopefully scale something, you kind of know what to expect. Another thing that we've actually used within our system to support scaling of a promising intervention, either within our system or even outside of our system, is there are various approaches to help facilitate that process. For example, learning collaboratives are a great approach that facilitate shared learning across different organizations that are implementing a common intervention or program. It provides technical assistance. So whether we're the ones providing the technical assistance or a different organization, it can just be a really, really beneficial process to allow for sort of that incremental tracking over time of implementation to see how things are going, and then to quickly pivot through the use of, we use plan, do, study, act cycles, which are really quick ways to implement a change, to test it out, see if it's working. If it is, great, move on with it. If not, let's pivot back, find something new and test that out. So those are things that we've used in the past that I think could be beneficial to really scaling a program into sort of day-to-day practice at various locations.
Can I say it?
Yeah, go ahead, Alan.
I love that, because that's the proactive approach. What aggravates me way beyond all means is sometimes we're slow here in Connecticut and we wait till we're up against the wall and then we act on it. We have all the data. I love data, but data doesn't do nothing when it just sits there. But I love, both of the approaches that because you're taking the proactive, you're doing the preventive. And that's a lot when it comes to, like, we're talking about complex care. You're addressing it before it becomes an issue where you have to do something to, and so I just want to thank you for sharing that, both of you. Thank you.
Yeah, it was Alan, you've summed it up nicely. These are forward-facing approaches that we can do and implement, and appreciate Amanda and Kara how you've laid that out so well. So we are going to actually transition into our Q&A portion. Thank you so much for this panel discussion, and I hope you are energized to read some and address some questions from our audience. So we're going to move into that. And in the first, I should mention, Travis, can you pull up the slides again so we can help? Yes. So to submit a question, please go ahead and click the Q&A icon located at the bottom of your screen, and we have people standing by to pull your questions and make sure we get to them. So you can go ahead and do that. And while we wait for other questions to queue up, Alan, I wanted to turn to you actually, and talk a little bit. And I know Kara, you've talked about this earlier, but how you can gain people's trust. This is a question from the audience: how you can gain people's trust so that they feel comfortable being truthful in the research itself. Your thoughts on that?
It's simple. Even I know Doris, where I saw some of the thoughts. It's peer support. It's people with lived experience. You have to talk to people. You just got to be real. You just got to you lived it, you share it. That's how you gain trust. If you can't talk from a point of being on the same level or something that you haven't experienced, you're not there. But when you have lived experience, or you're we push a lot with peer support, recovery support. If you talk level to level, eye to eye, that's how you gain trust. But if you talk from a point of you just know it from what you just think or you observed, or you don't have any knowledge of what that area or that individual or that family is going through, you just have it unlimited without getting the information of peer support. We find here, when we utilize peer support, there's a lot more. It could be mental health, could be recovery, but when you utilize and throw someone with lived experience in there, you get good results. You get positive results.
Doris, I see you're shaking your head, and I imagine you want to jump in here too.
Just basically peer supports is crucial and should be at the very foundation of all that we do. And some of us have had the fortunate experiences where we do, and if not, we become advocates, and then we're seen as adversarial, as was mentioned before. But my peer supports, my children have had peer support. They've been peer supporters at a very young age. So we start from the beginning, and that's culturally what we've done as villages and in small social networks, because we are our own trusted messengers, and we need to go back. Not go moving forward without going back, but where our foundations lie, and with the villages and with the shamans and with, you know, everyone gathering together, the village. We need to go back to that. So thank you for Ellen for mentioning that as well.
That sums it up really nicely. I'm going to keep going through our audience questions because they've got a lot for you guys. How do you identify the right research partners? Kara, I might come to you for this one.
Sorry. Yeah, I mean, I think past experience, we have, you know, I work in a really large health system. We have a lot of folks that we can connect with on our end, but they have partnerships with communities. They have partnerships as, you know, members of communities with other individuals who may be a great fit for research. It's kind of like that snowball effect, right? It's not like I can just go out and know who to talk to. I need to talk to other people to identify who to talk to, and then leverage those relationships that they've already established, very similar to what Alan and Doris have already said. Leverage those relationships to then hopefully engage people more strongly in a research project that's going on. So I don't know that there's any sort of you know, formal way that you should do it. I think it can vary from project to project, but yeah, just reaching out to those who have those relationships, I think, is critically important.
Great. Yeah, I think the, you know, coming down to relationship building and partnership, and that really, you know, breaking down the silos among different organizations and having that kind of cross-agency collaboration is a way in which you can identify the right research partners and really elevate the patient experience as well. Another question from the audience, and I'm going to leave this open and someone can jump in. How do you get buy-in for studying disparities as part of this work when the funding environment is not always easy for this? Yeah, this one's tricky, right? So, you know, it's we certainly need resources and skills to be able to better understand what we're talking about. And I think one of the things that we often neglect is really figuring out how to resource the right areas and how to you know, generate and use the funds in a way that can support better outcomes. Doris, I see you have your hand raised. Do you want to jump in?
Quickly, actually, sometimes it's just staring you right in the face. We're experiencing that in Connecticut. I'm now the chair of the Connecticut Council on Developmental Disabilities, and we're federally funded. So we're not, you know, reliant on the state or anything of that nature. We're trying to grant and give away $50,000 per organization or per project per year that meet our state plan. And a lot of organizations or a lot of silos don't see where disabilities connects with anything that they're involved in at the grassroots level, when it's involving, it's in everything. Disabilities in everywhere. So it's a matter of stepping outside of your comfort zone too, and looking at grantors that you typically don't, because there are a plethora of opportunities out there. We're just pigeonholing exactly what we're looking for, and we're seeking out. We reached out to over 100 organizations, and it's been hard to give away money.
Yeah.
Thank you.
Yeah. Thank you. I'm going to go to, we're running out of time soon, so I just want to be mindful of getting to a couple more audience questions. This one, how do you have do you have a measure for, sorry, I'm getting this question confused with another one. So I'll just highlight that quality of life and subjective well-being measures are often confused by a researcher. Do you have a measure for SWB once the toolkit is implemented? So I just want to take a moment and, kind of draw our attention back to the research agenda, where we talk through, and one of our key recommendations is to have outcomes, establish better outcomes in a more consistent and patient-centered way. And the lack of some consistent evidence base, as you know, and we talked about it, was the need to build in some, this project to work on a research agenda to address that. And we are interested in and recommend that there be more validated patient-centered measures in complex care, including in a number of categories. And sorry, I went on mute. One of the things that we can do is ask about, one of the categories that we are interested in, of course, is, patient-centeredness, racial and health equity, and these measures will provide us a bigger sense of the value that we have in complex care research and translating that into better practice. We have time for one more question. So do you have any recommendations for trainings available to those who will be engaged with research partners to ensure understanding of roles and rights and responsibilities? Yeah, we certainly need more opportunities for trainings, and that goes under that piece that we've been talking about of the skills building that's going to need to happen across all areas. Do others have ideas here?
I would just like to touch on that topic. I understand that, many of us are pressed for time and resources, and we're always looking for something that is the most convenient, i.e., like, for example, something that's prepackaged that we can access and use. Sometimes that training doesn't have to be a formalized technical assistance training. You can call training giving somebody just, a 5-minute prep session. These are the roles and expectations. We're providing that to you verbally. We're going to give you this handout, or we're going to give you the slide on the screen, give it in alternate formats. It can just be part of that conversation about the explanation of what is expected from both sides, because any of those interactions and relationships should be, mutually beneficial and understood from both sides, right? So I think using the word training sometimes trips us up, because sometimes it's not just a formalized training. It's having that conversation around, this is what we're doing, this is what we want to do, and this is how we hope to do it, and this is how we hope to include you in what we want to do. And this project was a great example of that. So we could call those prep sessions trainings. Mm-hmm. You didn't get them from an outside source. It's just something that we did as a matter of practice throughout this whole process. So I understand people want to find something that's prepackaged, but that's not always necessary. So sometimes it's just being a little bit more thoughtful about, we're going to call this a prep session, and that's going to serve as the training for not only both either the research partners, the clinical partners, but also, anybody else that you want to include in whatever process you're doing.
Thanks for that, Melissa. I think that sums it up really nicely. And we did have some really great workshop sessions that I think people felt like we were all gaining skills and learning together. So thank you so much for your participation. I really appreciate you all taking the time and having this discussion with us. And I know our audience had lots of questions. If we didn't get to your question, we have them for us here, and we will go through them and just find ways to be able to address some of those. So Travis, if you could put up the last slide, please. So we just want to talk about some opportunities to learn more. We have a national center, the National Center for Complex Health and Social Needs have a conference coming up next week where we will have a workshop and be able to talk more like in depth and have another panel discussion about the recommendations in the research agenda. And we'll have what's called a beehive, which is sort of an informational session that people can drop by and see executive summaries of the research agenda and talk with folks who developed it and worked on it. So to view the research agenda, please go to our website. And you can, of course, use the QR code to bring it up there as well. I want to thank everyone for your time today. Appreciate you joining us in this discussion, and we'll see you soon. Thank you. Take care.
Thanks, everybody.
Take care. Great job.
Gracias.
Great job, Doris, Melissa, everybody.
Great job,
And
Melissa and
nice meeting you,
Alan.
man.
Everyone.
Take care.
It's a pleasure.
You too.
Yeah.
I love the universal
Jen.
design.